1分钟的时间了，这个时间宝贵，不要耽误到任何1分钟时间，我就很简单的帮他先介绍，好不好？那后续以上那个问题再拜托你。OK，thanks，谢谢。OK 啊，各位安利登的朋友晚安，我是曾世昌，非常开心呢，在今天晚上跟大家相见哈，都是老朋友。那么今天呢，我非常荣幸的请到，事实上是我马来西亚最好的朋友了哈，Dr. Lau，为各位来谈一谈有关于颞颌关节的一些处理原则，以及一些案例的分享。那各位可能不知道，Dr. Lau 原本应该是要去念医学系的了哈。但是因为因缘际会呢，他后来选择了牙科就读。不过非常难得的是，他一直没有忘记作为一个医生的天职了哈。换句话说，他对于这种全人治疗，他投入相当多的心力，这是我个人非常佩服的地方。那特别是所谓的 TMD 了哈，Temporal Mandibular Joint Disorder 的处理哈。那我想以一个开业医的角色，他的确是提供了 TMD 病患最大的治疗的 capacity 了哈。那我想今晚的内容一定相当的精彩，那么请各位仔细的聆听，必定收获满满哈。那另外，因为今天刚好有马来西亚以及新加坡的牙医师一起参与，所以请容许我讲1-2句英文来表达我们台湾对于这个马来西亚还有新加坡这些老朋友也好，或者新朋友也好的一些欢迎了哈。OK，Hi guys, thank you so much for joining us tonight. I'm Edward from Taiwan. Actually, I take pride to present you Dr. Lau, our speaker tonight, for the topic of the TMD, also known as temporal mandibular joint disorder. Dr. Lau maintains private practice in Kuala Lumpur, and actually he is dedicated to the total patient care, especially the management of the TMD. I believe his insightful lecture will open our eyes and help us benefit our patients more than we thought before. Ladies and gentlemen, big hands for my best friend in Malaysia, Dr. Lau. Thank you so much. Dr. Lau,
Thank you very much.
you're okay?
Yeah. So 我们现在可以开始是吗？
是的。
Okay, good evening, everyone. One moment. The Zoom start to act up. Okay, good evening, everyone. I'm Dr. Lau Keng Hong from Kuala Lumpur, Malaysia here. Many thanks to Dr. Eversons for his kind invitation and also in providing me with this wonderful online platform to share with you my treatment approach towards TMD patient in my daily practice. To start today's presentation, I want to provide this dialogue with a patient who came to my clinic recently for an extraction. So during the extraction, I found that the muscle was very tight, but the patient was not aware at all for this muscle tightness because he thought that this is non-issue and he doesn't know that the dentist can help. I must apologize to those non-Chinese speaking audience because those dialogue that I'm presenting today, they are either done in Mandarin or Cantonese. So I'll try to translate here. The summary of the conversation, of course, this patient was trying to say that dry needling, muscle stretching, relieve her muscle tightness. And also by correcting her posture, she noticed a slight change to her bite. And I gave her some this online app called Brux app to make her aware of her jaw bracing and clenching problem. So this is a case where in order to facilitate my extraction, I I have to actually make the muscle a little bit easier for me, for her to open the mouth. And eventually, of course, the extraction was uneventful. Because of this dialogue, I think I have these 5 questions for you. I hope you can find the answer from the dialogue or along the presentation today. So let's hear what she has to say.
现在目前没有声音。
哦，对，声音。
放松这个两边的肌肉。2月的时候我嘴巴开的时候，或者是left right 的时候会比较辛苦，所以现在做完了，我稍微现在就松了很多了。
你觉得你不是很怕针吗？
啊，对，我怕针，恐分怕针。
像我们做了几针啊？
做了4针，是蛮痛一些的，蛮酸的，不过应该是值得吧，因为这个已经是很久了这个问题，因为我不知道是找谁解决，所以我以为是是正常的，所以我就是这样子，我不知道。所以当医生说这个是不正常的痛，我才知道说这个问题在哪里。现在
肌肉僵硬，可能要向左向右的时候，尤其是一边好像完全都不知道去哪里走，对吗？
对对，刚刚开始的时候做完很难移过去，就有东西拉着这样，现在没问题了。
那还有一个很重要的就是我们讲的 posture 对吗？
对。
我们有做一个动作是什么贴墙对吗？
对。
现在做完了这些东西之后，有一个很奇怪的东西出现是什么呢？
当时我不知道医生叫我贴墙，我一直是练我的站的姿势还是什么。不过刚才玩的时候跟医生交谈的时候，我发现到我的牙齿的那个位置好像比较正确了，要不然我会觉得很紧绷。牙齿靠在 each other 上面的时候会有点紧绷，现在比较放松，好像比较对位这样子了。
就是说咬合有一点点的不同样的。
对，这个是事实，所以我才感觉到有什么不同，所以我才问医生为什么我的咬合会好像调回去还是调回来。
但我们还有一个很重要的就是那个 brush app 对吗？
对。
那一个东西用来干什么呢？
早1个礼拜的时候，医生叫我download这个 app 的时候，我觉得头头我还不觉得什么，后来我开始的时候就觉得很好用，而且我这边讲老师都会松了很多，因为他一直提醒我，一下子他会 from 那个 message 来的时候，我就开始要回答，然后我会提醒自己一下，不要盖到这么紧啊那些，我就开始在放松。我个人感觉有好处。所以我还会再继续用的，因为这个毕竟都是几10年了。所以现在我刚刚开始，我觉得我还要一段时间才慢慢的洗脑。
他那一个 program 其实是在提醒你，白天的时候牙齿是来吃东西，不是来发泄情绪的，不是咬紧绷那种。所以他每一次提醒你的时候，你就会把下牙齿松开。
是这个是的。他一播出来，我就开始我现在有在咬嘛。其实讲老师刚刚开始的时候，我是真的还在咬。我不知不觉的，我没有 realize 上，就医生跟我讲说，我们白天的时候也要注意，因为我之前有戴 night guard 的，说未必就晚上会咬牙，我不知道白天有没有咬牙。说医生跟我讲的时候，我才知道我白天有咬牙。这个 F 用后，我才知道我真的是在咬牙，因为我咬着在那边，我没有讲话，我就咬着那边，等到那个 message 播出来，我才想我在咬着，所以我就开始放松，
好了，首先我们要说的是你的。
So this actually brings us to the topic of that. So who are we actually in this whole context here? I'm sure every one of us know that we are dentists. We are the doctor of the orificial region. But I believe we should have a role to play in the area of ENT, cervical vertebra, and head and neck. Then why do we need to understand TMD? Most of the time, patients who walk in through the door and they are not coming in complaining about this muscle joint problem. But I think we still need to understand TMD in order for these 5 reasons here. That makes our job easier, just like the patient who came. If you find that the patient couldn't open the mouth really wide, it's going to jeopardize your work quality. You are going to have a hard time to do the work. And sometimes, if you look thoroughly enough in the mouth and you cannot find anything wrong with the teeth, the pain might actually come from outside the mouth. There could be a possibility of what we call a refer pain. It can come from the muscle, it can come from the cervical vertebra. With that knowledge, that also will prevent us from any, unwanted legal dispute because of our misdiagnosis here. And of course, the knowledge of TMD also will equip us with enough what we call providing a quality healthcare in terms of airway, in terms of sleep, and the cervical vertebra here. And of course, lastly, is that during any long treatment that we are providing, there will be some certain day that we are not so lucky, and there will be some crisis here with the patients with the TMD here. And with this knowledge, I'm sure we can handle it very well. So before we proceed further, these are the group of excellent clinicians and lecturer that has helped to shape me to who I am today. Especially this doctor in the middle of the photo, Dr. Alex Chen. Last year, I was fortunate enough to spend about a week in his practice, and I witnessed for myself firsthand, how he waved his magic wand using acupuncture, dry needling, muscle stretching, and the knowledge about the cervical vertebra in dealing with patients with orofacial pain and TMD. I'm sure if you have opportunity to learn from him, I urge you not to miss it at all. Then talking about TMD, I bring up this issue about etiology. This is how I classify them for TMD etiology. The first thing is always the muscles. The things that can cause muscle issue include sleep bruxism, patients who clench, and there's also problem with the joint. The macro trauma is like a physical trauma, directly injury to the joint, or micro trauma like those who are like what we call parafunctional habit like nail biting, or even us asking the patient to open their mouth far too long, that also can cause some issue with the joint. And with this joint issue also will bring about this displacement. TMD patient always come with this psychology trait, which is like they are stressed, they are anxious, they are depressed, they always have some issue with sleep. In this sleep topic here, I might highlight some relevant things about vitamin D. The other thing that we cannot run away for every one of us is about aging. There's degeneration that is happening along the way, something that we call osteoarthritis. Posture. Posture has everything to do with, eventually to do with cervical vertebra. What kind of posture? Posture that might be related to airway, something habitual, something due to the occupation, that also will lead to TMD. And connective tissue disorder, be it genetic or autoimmune, these are the situations that also can bring about TMD problem. And last but not least is occlusion factor. I think this is a little bit controversial among even dentists. Some say yes, some say no, but I will have to tell you that malocclusion coupled with other factors is going to cause some TMD issue, especially for those who have lost their posterior vertical height. That is what we call the support. And there's other things like what we call the ICR. This is something that we don't even understand till today. The reason I bring about this etiology is that, patients walk into our clinic, we treat them to their complaint. But if you do not have a thorough look about these underlying causes, the complaint the relief that you provide them might be only short-lived. Hence, today we only have 1 hour. I might not be able to cover all, but I will try to pick up those that we are going to see in our practice. So like I said, the management part, patient might not come in to tell you that I have a disc displacement or whatever. They are probably going to tell us that, oh, I can't open my mouth wide, I can't chew hard food. Or maybe they will tell you that I have a crown fracture, feeling cracked. And if you were to probe further, then you are going to realize that they have headache, migraine, ear pain and tinnitus, sometimes eye pain, jaw pain, or neck and shoulder pain. But actually it becomes very confusing to every one of us. The main thing about the treatment that I actually divide into 2 categories. We are dealing with the muscles, we are dealing with the joint. So muscle also, you can actually subdivide them with a myofascial pain, with or without referral, myalgia, myositis. The joint part, you can have a joint pain, and you also can have a disc issue at the displace, with or without reduction. And of course, the other part is the degeneration, osteoarthritis, and inflammatory joint disease. The animation down there is for those young dentists who are not familiar with what we call what is meant by this displacement reduction or non-reduction. But all in all, when we are trying to treat this muscle and the joint problem, we shouldn't forget about the etiology of it, because that is a more long-term solution. So talking about aging and this osteoarthritis, whatever causes behind it, there's always element of muscle overloading. Courtesy of Dr. Daniel Tamimi, I tried to give you the pathogenesis of osteoarthritis. Like I say, whatever causes behind, this initial trigger of the muscle overloading will actually happen on the condyle and the TMJ unit, and this will cause inflammation. It can be synovitis, capsulitis, and subsequently, this inflammation will cause some degradation of collagen, and the collagen is found on the articular surface and also the TMJ ligament. That is a very important part of it, because the minute when these things start to happen, we are going to see subchondral bone changes and a compromised TMJ ligament function and integrity. This is why edema of the bone, you see sclerosis, erosion, and the laxity of the ligament. This is subsequently, if you were to allow this inflammation to progress, you are going to see a laxity of the ligament resulting in this displacement, and even to the extent of this perforation and osteophyte formation, and what we call a cyst, subchondral cyst, and a chronic, long-term chronic inflammation of the joint might lead us to fibrosis and scar tissue formation. If you see your patient suddenly developing anterior open bite, sometimes you have to consider that part and check their history. So let's go back to some basic. Temporomandibular joint is what we call a synovial gangliomo-arthroidal joint. This is a hinge and a sliding movement kind of joint. But that's what we use it for our semi-articulator, adjustable articulator, which we use a lot for our prosto work. But is it really true this condyle, the joint is what we call a ball and socket joint? I think today a lot of evidence has been telling us that we are not expecting the condyle to rotate, pure rotation for the first 2 cm, and what we call a translation. But today is about TMD, hence I shall stop here telling you that the TM joint is not a ball and socket joint. Then what is overloading the TMJ unit? Of course, it's the muscle of mastication. I used to believe that they are functional unit means muscle opening and closing, but a lot of time they do co-contract together, especially when we have bruxism. We have to stabilize the jaw during chewing, swallowing, speech, and when we are stressed, when there is infection or malocclusion, that you have to stabilize the joint, or any neuromuscular disorder, this co-contraction can lead to muscle fatigue if it's a long-standing one. Apart from the muscles, we also need to know a little bit more about the TMJ unit here. The TMJ unit, very often that we use CT scan to view them. I do not want to go into details of what they call the posterior zone, intermediate zone, anterior zone. This, I believe, you'll be able to pick up from the textbook. But a lot of time, if you look at the CT scan from the X-ray view, you actually can tell from between these two pictures here, one with the more space, one with the less space. And this less space, that if you were to measure, probably from this one on the right-hand side, you can quite confidently predict that the disc has been displaced. But for you to see the disc, I think it's only MRI. You have to use MRI to look at the soft tissue pathology in this joint unit here. The TMJ ligament is one key factor which I think all of us need to understand. They are divided into main ligament and the accessory ligament, the capsule, the collateral ligament, and the temporomandibular ligament. And they are also what we call the accessory ligament, sphenomandibular and the stylomandibular. The whole purpose of we are talking about ligament here, apart from knowing the anatomy, the insertion, is actually the role of it is actually to stabilize the joint. It doesn't allow complete freedom of our jaw to move. it has to stabilize it that way. These are the role of the ligament. So in order to understand a little bit more of the ligament, they are actually made up by the what we call type 1 collagen. And the type 1 collagen here, they require amino acid like glycine, proline, hydroxyproline, and vitamin C, vitamin E, and copper-dependent enzyme called a lysyl oxidase. Just imagine when we talk about inflammation causing the degradation of collagen. What about patients who have deficiency, who have issue with what we call malabsorption here? So that is the reason why I say, apart from the inflammation, the causes of laxity of ligaments, you cannot rule out patients who are having malabsorption here. Then the other two orthomandibular ligaments are the funny one. We call the distal malleolar and the anterior malleolar. These two ligaments join to the malleus, which is one of the oxicles of the middle ear, and they join to the TMJ unit here. So sometimes when we are treating TMJ, TMD patients, we might accidentally help the ENT doctor in solving tinnitus and some ear pain issue. The muscle of the neck and shoulder, why are we required to know them? Is because of posture. Patient who come in with pain of the muscle, you want to learn the origin and the insertion, and you know where are they and the function of them in order to palpate and to find out where is the pain and the muscle not here. So here we are talking about suprahyoid, infrahyoid, and the muscles of the neck here, and the pharyngeal constrictor muscle, which is involved in the speech and swallowing, especially the middle pharyngeal constrictor. Hence, this one unique bone we call the hyoid bone is something that we see so often in our clinic, especially when we do the SEF. So this patient who come in for some treatment, when I took the SEF, he was complaining a lot about the pain here, the muscles and the neck. So out of curiosity of this SEF that I did, you can see from the SEF here, the hyoid bone is very much depressed. What it says is that there is an imbalance of the muscles between the suprahyoid and infrahyoid. And this is one of the indicators for patients who might be suffering from apnea. Hence, I took the patients for the sleep pulse oximeter, and true enough, you can tell from this result, you're 65%, which is the very low SpO2 for him. So I would want to encourage you, every time when you study the hyoid bone, the SEF, so this is one clue that you can pick up, patients who suffer from apnea. So here comes the posture issue. I'm sure everyone of us are very familiar with this first photo here. We dentists, actually, a lot of time, if we are not employing a good posture, we might have problem with our muscles. Those ladies working in the office with a laptop computer, and today with the IT, we watch and, we call spending too much time with the screen of the handphone, and occupation-wise, the long-distance driver and athletes who do not observe a good posture, that these are the posture that can cause muscle pain. So patients who come in with a muscle pain, apart from treating their complaint, you will want to know what is the source and the cause behind of this DMD, especially the muscle part. When we talk about posture, there is always related to cervical vertebra. So if you see from this picture here, this is a normal with a lordosis here. Eventually, patient with the wrong posture, and they will straighten up. We call the military neck here, and until we have lost the lordosis, until it's called kyphotic. When we do chin tucking, we are trying to develop this good posture here, but can we do that? So this is actually one very big important element about posture here. So forward head posture is something that we see so often. And a patient, a lot of study on this. This study is saying that the forward head posture, the condyle actually will move posteriorly, or rather I should say the jaw will move posteriorly. With patients with this kind of highly stressed situation, if they were to even clench further, there will be injury to our TMJ unit. And you also have to notice about the hyper position. And this is the beginning of forehead posture. Eventually, let's say patient were to have developed some erratic breathing pattern, they will use an accessory muscle more than the diaphragm. There will be a shift of the center of gravity because of the head being postured forward. Then what we call upper cross syndrome will develop. There is a two different set of muscle here. One is tight, one is weak. And this kind of dysfunction actually will lead to some problem with our joint, especially at the C4, C5, T4, T5. So the risk of cervical radiculopathy, which is the pain that can ensue, is something that we cannot overlook. When we talk about posture, that is one thing leading to the cervical vertebra. This very big important nucleus, what we call the trigeminal spinal nucleus, is all about this posture issue. Thanks to courtesy of Dr. Lucas Lassman, which I actually borrowed from his animation here. You know, the sensory nerve of the trigeminal nerve, once they have gone through the trigeminal ganglion, instead of going up to the thalamus, to the cortex, they actually descend into this part of the brainstem where they have these three nucleus, cranialis, interprolis, and caudalis. This is also where our cervical nerve C1, C2, C3, or even sometimes C4, they also end up in this nucleus before they ascend to the cortex. So the relevance of this trigeminal spinal nucleus is that our brain sometimes interpret the pain from the neck and they get referred to the face, even to the oral region. So, and it can be also vice versa. So we must always remember the pain that sometimes you cannot find any fault with it, you have to look elsewhere. And trigeminal spinal nucleus is one key player here. There comes this issue about sleep. I think we Malaysians are very fortunate to have Dr. Chen Yi Hong, who has started our Dense Sleep International in Malaysia. For those who are interested in sleep dental medicine, I urge you to sign up for her course. It's very comprehensive, very impressive. But today, I'm not going to talk too much on sleep, but it is important for us to know sleep is restorative. You have a good night's sleep. And it's also essential in healing TMD. There is something that you have to talk about sleep is adenosine, melatonin, and patient sleep hygiene. If patient is not sleeping well, they are not going to have what we call a chance to heal their TMD. And blue light, circadian rhythm is a lifestyle of the patient, the ambience of the room. And there's one part, big part of the nutrition, a lot of us are not paying much attention to it. And this vitamin D here, the deficiency is really widespread among us. If you were to care enough to take a blood test for your patients, you realize that a lot of them are really highly deficient in that sense. FDA only recommends 600 to 800 IU. But is this dosage in optimum for sleep and for the vitamin D anti-inflammatory and the role as an immune modulator? So apart from nutrition, there are so many factors that involve. Patients who are highly stressed, they would have an imbalance of what we call autonomic nervous system. You have drugs to reduce the sympathetic nervous system, but we don't have any drugs to increase the parasympathetic. That is something that you have to have a proper lifestyle to have it. And lastly, patients who are definitely not healthy, they are going to have problems to sleep. So since we are talking a little bit about vitamin D here, this is the whole chemistry about vitamin D, as in how we synthesize melatonin. From tryptophan to melatonin, there are so many cofactors here in order to turn them into 5-HTP to serotonin and to melatonin. Why am I saying so? Because vitamin D receptor, they are vastly found in the hypothalamus, in the pineal gland, in substantia nigra, the midbrain there. It is one of the very important ingredients, what we call cofactor in the synthesis of melatonin. So if your patient is deficient in vitamin D, would you not want to improve their sleep so that we also can treat their TMD better? So talking about vitamin D here, the synthesis here, there's one middle part is called serotonin. I want to highlight to you, serotonin is actually one of the key players for psychiatrists. People who are depressed, they are very low on serotonin. Most of the time, the first line treatment, the medicine that's prescribed to them is SSRI. What it means is that you're trying to recycle the serotonin, whatever serotonin which is available to them. If the patient is lack of serotonin, according to this cycle, how would they be having enough melatonin here? And because of that also, the essential nutrition, the vitamin D and others is important. If you don't sleep well, you are going to develop what we call sleep disorder and bruxism. TMD is definitely the end result of this type of patient. And the study here showing the low serotonin level happens very often in those severe sleep bruxism patients. I do level 2 polysomnography in my practice. And I heard a lot of time even from our dental colleague, bruxism happens when patients have apnea. I'm purposely brought up this report to show and share with you that this patient who came to me and having some dental issue and a mental health issue, seeking some very comprehensive dental treatment, which I'm a bit reluctant to do. So the sleep report here said that the total sleep time, you can be sleeping enough. 7 hours and 41 minutes is actually not bad at all. But if you look carefully, she has got very low entry, which is the stage 3 sleep, what we call the deep sleep. It's only 1.7%. Ironically, the AHI is only 1.6. There's no sleep breathing disorder at all. The arousal index is actually very high, 9.9 per hour. Hence, when we look at the ratio here, the arousal causing bruxism is 3.8. Way bigger than the cause for the apnea. Hence, this is the reason that I must highlight to us. Grinding at night might not be due to breathing issue alone. It also can mean the patient is not sleeping properly. There is a lot of what we call sleep arousal here. So here come the common treatment for myogenic, for our TMD. I put them into myogenic and the joint, but basically they overlap a lot of time. We use drug and I don't use drug. The basic one, heat and cold therapy, I believe everyone knows. You can use something fanciful tools like this TENS, what we call the J5 from Myotronic, is more like aiming on the gate control theory on pain. Also, I love to use a lot of physical therapy. You're trying to stretch just like the physiotherapists, and dry needling is one of the main tools that Alex Chen has taught me well. And I also like to highlight to my patient, don't ever think that you grind and you clench only at night. Biofeedback is one of the big issues here. I use Bruxab to make the patient aware that they are also clenching and having a lot of parafunctional muscle bracing during daytime. For those who have stress issue, I refer to the psychiatrist or even psychologist. But if you think you're good enough to do this CBT, you can do that. Do I use occlusal splint? Yes. Depending on the case, not all cases I use occlusal splint. If I find that, let's say, after arresting their TMD issue, there is issue that with malocclusion, we can treat that with orthodontic or prosthodontic. But all in all, patient cannot rely on whatever way that we do. They have to have a very good self-care practice, as in their sleep hygiene. You also need to teach them some jaw exercise. And I also do blood tests, and from the blood test, I will give directly advice. These are the drugs you can give: relaxant pain, topical way, or Botox, trigger point injection, like nutraceutical. This is something that will become handy to adjunct and to help out with a non-pharmacological way. On top of this way, if there's an issue with the joint, you can go for steroid injection. Sometimes you can go for hyaluronic in order to have put in more lubrication. If all this fail, arthrosynthesis is the other way to do. And if the patient is actually, the problem is very what we call recalcitrant, you would have to end up sending to your surgeon colleague to do arthroscopy and open joint surgery. Today, I want to highlight a little bit on dry needling, which is something that I do very often. When we do dry needling, it's actually all about muscle knot, also called myofascial trigger point. These are the small patches of muscle tissue that remain in the state of contraction. This state of contraction, there is a restricted blood flow and a localized inflammation and pain. Why would it happen? Actually, definitely, if you overuse your muscles, you strain it, you injure it, there's a stress and tension, we call the co-contraction, nutritional deficiency, lack of magnesium here, that can cause muscle knot. So dry needling is actually having a local and a neurological effect.
除了这左手边有吗？就是右手边这个位置。OK， 你这里。松了，松这边，松了，松，松了，这边，松。这个 dry needling 做完之后，现在的感觉怎样？
开个不有什么痛的，
没有什么痛了。OK。
You can see that the effect is rather quick.
对。
So, to master this skill, I think you add on extra tools for you when you come to your daily practice. Sorry, I need to go back to one slide. Bruxism and biofeedback therapy is something that, like I say, we want to make the patient aware there must be a physiological rest position during daytime. This is also a space that we hope we can allow some room for breathing space for the joint here, so that we can have what we call a circulation of the blood and the nutrition over here. So patients, sometimes they are not aware they are actually doing what we call, clenching here. So if they were to clench, like this patient is not aware at all during daytime. We snap this video during when the patient is not aware, just to show him that he's clenching. So some patients don't believe that they clench, or they don't grind at night. You actually can use a simple tools like a splint painted with something red here. 1 or 2 days later, you ask the patient to take photo, and this is going to leave a mark and show the patient they do clench and grind at night. For that, this is the night guard that I always prescribe if it's necessary. It has to be what we call a bilateral simultaneous equal intensity contact, so that we want to give some support to the joint here. So blood tests, I'm actually looking for metabolic disorder and nutritional deficiency. I do that quite often instead of using drug. If I need to use drug, I will use that. When we talk about this, because just now we talk about inflammation. So inflammation here, every time where we have injury, patient muscle overloaded, there is an injury here. The first thing that happens for inflammation is what we call is an interplay between all these chemical mediators. What their aim is actually to recruit and activate our immune cell. And at the same time, you also want to alter the blood flow and increase what we call the vascular permeability. And the whole intention and also is actually to stop this inflammation, and once that thing, it can be stopped, arrested, you want to go into resolution. And last time we used to believe that this is resolution of the inflammation is something passive, until Charles Serhan discovered that this is no longer what we call a passive process. For patients who continue to clench and injure their muscles and their joint, you don't have any chance, and the health of the patient, which is compromised, you do not have this, what we call phase going into resolution. You will turn into chronic inflammation. If the body cannot cope with it, this is going to form a cyst. If the body is like fail to resolve this inflammation here, there is a persistent and continuous injury. It's either they go into chronic inflammation or the what we call highly activated macrophage here will actually activate the fibroblasts to lay down a lot of collagen. This is what we call a healing with scarring. Fibrosis is happening here. So chronic inflammation, we tend to believe that inflammation can only be dealt with drug. But if you take a look carefully, drug can actually, we use drug for patients before surgery. We are trying, drug is actually to, instead of talking about resolving the inflammation, we are trying to inhibit inflammation. You are trying to stop the immune response. But immune response is essential for inflammation because acute inflammation is a process of the body trying to ward off, neutralize the, what we call the threat, so that we have a chance to resolve and heal it. So here the drugs is, the role of the drug is never in the resolution here. To have a proper resolution, the patients, first of all, must stop this injury here. And then with a good nutrition and sleep and health, the body has a chance to this. And resolution, it is not about inhibiting and stopping the immune response. So you have to choose to resolve or to inhibit here. There comes case one of our today. Eva is an 18-year-old Canadian student, came year 2022. You see that she has pain.
I can't move farther than this unless I like readjust.
You see that she has to shift the jaw to the right to open the mouth. She suffered from headache, ear block, and she was given a soft spleen by other dentists before she came to see me. She also has seen the psychiatrist too, given orphanedrine. This is a muscle relaxant, Lexapro, the SSRI, Xanax for the anxiety, and some antihistamine for the allergic rhinitis. You can actually see from the video that the range of motion is normal. When I palpated the muscle, the pterygoid, suboccipital, SCM, splenic capitis, they were all very sore. The funny thing is that when you this kind of range of motion, you might think that the joint is okay. But when I did the load test, both the right and left TMJ were very, very painful. She has got a poor sleep hygiene. She slept at about 1 to 2 o'clock because she's a high academic achiever. And she told me the sleep quality is poor. She doesn't feel refreshed after waking up, but the duration is okay. Let's take a look at the intraoral picture. You can see from here, this is a forward head posture here, one of the recipe for muscle issue. The posterior teeth are all lingually inclined, and you can see the attrition here. Let's take a look at the CT scan of the thing. This lip oxygen here shows normal. If the space is there. I think the important finding in this CT scan is about the condyle. If you look at the condyle carefully, she has lost the outline, flattened out the condyle at this young tender age. Both sides, left and right, you can see they are all flattened. When I check her blood test, she has got deficiency in vitamin D and B12. So what are the findings that are with this lady? This is very likely what we call early ICR, the idiopathic condylar resorption, because the rheumatologist and the psychiatrist didn't find anything wrong with the systemic joint, any other joint in the body. She also had what we call myofascial pain with referral to the ear block and the headache. There is a displacement on the right-hand side with reduction, but there's intermittent lock. Definitely, she has got sleep bruxism according to the mom. Is it due to the Lexapro or is it due to the stress and anxiety? I do not know. She has got vitamin D and B12 deficiency here. The management, I released all the tight muscles. I gave her a set of home jaw exercise. I gave her some medication. I asked her to download Bruxap to deal with it. We talk about stress and sleep management, also about some posture issue here because the study there, she said to me that the one in Malaysia is not as good as the one in Canada. So I gave her some nutritional support by looking through the blood test, and I told her to stop the soft spleen because she also said that the soft spleen given to her by the other dentist actually even trigger more chewing. She tend to take it like a chewing gum. We have to talk a little bit about what we call ICR here. What is ICR? It's also known as what we call cheerleader syndrome. It's something really uncommon. It's a degeneration here, primarily affecting teenage girls, especially during pubertal growth spurt. I went through some paper. Some say it's related to estrogen hormone, but this is highly controversial. But definitely there is a dysfunctional bone remodeling here. So ICR is a diagnosis of exclusion. When we rule out other local and systemic conditions, and we see this kind of resorption over the condyle at this young age, it's likely to be ICR. As the name suggests, idiopathic, you do not know why. After 3 rounds of therapy,
A lot smoother, right?
she was very, very happy after 3 rounds of therapy. She has no more what we call, she doesn't need to move the jaw sideways to open the mouth. She doesn't have the pain. Young female with condylar resorption here without any systemic joint disorder, I think we have to consider ICI here. We don't have any treatment to reverse that. The treatment objective is to reduce further mechanical stress on the TMJ unit. Hence, we have to release all the tight muscle, improve the posture, emotion, lifestyle, sleep hygiene. I asked her to stop the soft spleen and also talk about breathing and myofunctional training for the sake of the breathing here. And we gave her some nutraceutical guidance. Patient didn't return for further check. ICR is something that I would encourage everyone to closely monitor because the destruction can be really severe. So unfortunately, I don't have further data with her. Case 2. Case 2 is about Mr. Tan's 66-year-old retirement. His complaint is actually a bit weird. He's complained of discomfort of the upper left quadrant while washing his face. So I asked him to show me how.
现在也没有。你在家里的时候，就是
This
这
is
样
how he
洗
showed
的
me
时
how
候，
he
你的牙
washes
齿
his
会有
face
酸
at
痛。
home.
是
现在是不会。
左边上面最少一个牙齿也觉得有点酸软这样。
So when asked about the medical history, he said no issue at all. The wife who came together interjected and reviewed the condition. Honestly, I was rather bemused. I have to tell you that be careful. Patients always filter what they think is relevant to our profession. They think that we are dentists. Hence, anything outside the mouth is none of our business. Actually, it is so important for us to probe properly. He actually suffered from neck ache with numbness and tingling sensation on the left arm. I think this is one very key important factor that I have to investigate further. He told me he tried chiro but didn't feel much improvement. He also said to me that before seeing me, he went around to seek some dental opinion. Some suggested root canal, and even worse still, one actually suggested extraction. This is red flag, yeah? Let's take a look at the picture here. another case of forward head posture. Overall, he has got multiple restoration in the mouth, but seriously, this is the left-hand side. I do not see much that is what we call very suspicious. The offending to eventually we pinpoint to what we call the 2-5. But the pulp test is vital and no mobility and no decay. When I palpated the muscle, these are the muscle they are tender. Because of the what we call numbness and tingling sensation that he complained, I asked him for a set. Actually, you can see from the set, other than a very depressed hyoid bone, there is what we call a loose osteophyte here. Is this actually caused by the bone or ossification of the soft tissue? I do not know. But there is also this is definitely, you can see bone spur here. There is a narrowing of the invertebral space between the C6 and C7. So in order to understand why the forward head posture, I asked the patient to do this simple test.
你感受一下呼吸。
OK，
OK， 我们现在开始退回。
I asked the patient to lean against the wall
OK， 收
and
下巴，下巴要收紧，
chin
手再
tucking
手。
to align the vertebra better.
你觉得呼吸
Told me that
如
he
何？
couldn't breathe.
好像胸膛被压住这样，不太能够
不能够呼吸，对
不
吗
能够顺畅呼吸的，好像压住吸气很浅短。
？OK， 你把头抬起来，现在呼吸顺畅了，对吗？但是看到路吗？
看到挺好玩。
说怎样要看前？如果我走路的话，要看前方，要怎么办？很难。
只能够看到45度了。
这样你要怎样看到90度呢？
要低头了。
你把头抬出来，离开墙壁，看前面。看前面。这样呢，呼吸又顺畅，又看到90度了，对吗？
对对。
So this is why I would call the sign of the spine compensating the airway space. So remember we talked about trigeminal spinal nucleus here. I think this is a referred pain from the spine. So the takeaway from this case is that we dentists shouldn't only treat cases when we know anything that is dental treatment. So the complexity of the innervation at the oral facial region is something that we have to be aware. The trigeminal spinal nucleus is something that we know. The numbness on his left arm, is it caused by cervical radiculopathy or thoracic outlet syndrome? Definitely, we do not know, but it's definitely not orthodontogenic origin. The discomfort is actually triggered when he bends to wash his face. This is the light bulb moment. Hence, I refer him to physiotherapists to treat the upper cross syndrome and the spine orthopedics to further assessment and management, especially the MRI to check whether there's any nerve root impingement. And I reassure the patient 2-5 is fine, nothing wrong with that at all. This is the last case today. June 2023, Madam Ming came.
仲開得大。
有時唔會嘅，你開嘅時候係唔會嘅，有時你唔知你諗開嘅時候，你會 jam 住喺度，唔會咁嘅。
嗰個頭35、38、35、38還好，你啱先。而家2-1。
She has struggled to slide. When I was trying to check for the range of motion, she struggled to slide the jaw to the right hand side.
行一個位嘅啫。啱啦，佢 OK， 依家你係去呢邊，我跟係咪？
It was very, very painful for her. So the history say that she has depression, anxiety. Ever since the husband was away 10 years ago. And very painful, the jaw going to, that's the reason why she was trying to, not to open wide. Surprisingly, muscle and palpation not too sore. The load test, the left DMJ was very, very tender. The intraoral picture that you can see, she has lost the posterior vertical support here. Many molars are missing. Hence, I actually gave her this little thing called a denture. When I checked further, she has got very low vitamin D and increased what we call inflammatory marker, the ESR, but there's no oxygen desaturation. So the CT scan on the condyle on the June 2023, I was shocked to look at the amount of damage on the left condyle. So this is what we call an emotion overwhelm and a suboptimal health. With the mechanical overloading on the TMJ apparatus, there's no posterior vertical support and causing inflammation and injury, eventually leading to erosion, osteophyte formation, and subcondylar cysts. The treatment render is actually using medication. I released the muscle, and I gave her a very important biofeedback there to tell her not to clench, and a set of jaw exercise and the breathing exercise to improve her parasympathetic mode, a new lower denture, and a night guard for her to wear at night, and the blood test and the nutritional support. This is 2 months review. The important thing is that she said the pain is gone. But if she doesn't do the exercise, the discomfort will reappear. It took her 2 months to get out from the suffering.
如果我一段時間，因為你教我做嗰個動作嘅時候咧，如果我係一段時間我唔得閒嘅時候，我就冇做，所以變咗如果我再做嘅時候，我
So what we call a motion is lotion here for this patient. That's the key takeaway here. This is 15 months review. She has regained everything, the range of motion. To my surprise, the left condyle start to remodel, we call regenerate here. The opening was only at 38 at that time. Now she could go all the way to 48. Basically, she's completely healed, apart from waiting for this condyle to remodel to get back to normal.
Very good.
To take away from this case is that if this is a classical osteoarthritis, while we deal with so many causes for her, the aim is to get the patient pain-free and resolve the inflammation. These condyles are the tissue with regenerative potential. Once we can eliminate the triggers, we have to give the room for the condyle to remodel. This is what we call good environment and the nutritional support. The conclusion is that why do muscle and the TMJ develop disorder? Are they autoimmune in nature or any environmental factor that cause it? We overload them. Or we are just born with what we call structural vulnerability. To effectively treat TMD, it is crucial not to ignore the underlying causes. Even this is autoimmune, it's essential to understand the initial trigger and the sequence of events. I don't share with you any autoimmune cases today. I do have that if there's any opportunity in the near future. To conclude today's presentation, I want to highlight to you this video clip about Kung Fu by Stephen Chow is actually inspired by my teacher, Max Chai Tzu. Let's look at this whole thing. This is the initial injury. Patients start developing this muscle clenching issue here, or muscle overloading, whatever causes behind. If this were injury to be one time, there's high chance for us to heal. This is what we call patients continue to injure themselves. So treat TMD is that we have to give our body opportunity to restore the homeostasis. It's our duty to advise a patient not to repeat the injury. So a lot of time patients are not aware on the part that they are actually repeating the injury here. So this is my famous quote from my teacher: no matter how advanced our innovation tools and equipments and knowledge may be, The true healing always begins with the patient and their commitment to the journey. So, allow me to take this opportunity to share with you, do a little bit of advertisement here. My teacher, Alex Chen, will be coming to Malaysia sometime in this April 26 and 27. It will be a 2-day seminar plus workshop. If any of you who are interested to implement TMD and to gain the knowledge of this, definitely Alex Chen is a good teacher to share with you and to guide you along. To bridge the gap between dentistry and medicine, he is the right person. His lectures and workshops are very clinically oriented. With that, actually, I thank you very much, Everett and Annie Dan. And if you have any question, I'm here to answer. Thank you.
谢谢 Dr. 老，哇，你真的是把我们台湾的大师通通都跟了一遍嘞！我发现，从蔡志梦，从这个师傅陈运之，对呀，而且我发现
你们都是很棒的讲师，
都是很棒的老师，对，而且我发现你的那个咬合板是这个德国医师那个 Elizabeth Menzel 的
对
做法，因为那
，Menzel 的，
一堂课我们一起在新竹上的。
是，
对，
我是他的学生。
我知道，我看到了那个老师们，他在你的右下角这边，我有看到他，
我其实
很熟。
全部都是我的好老师。
真的，我都从他们身上学到非常非常多的东西啦啊！这边有几个问题要请教一下，请问一下 dry needle 的尺寸长度是什么呢？那在使用 dry
它
needle 的
其实
时候有没有什么诀
它
窍？
其实是跟那个，它其实是跟那一个我们做 acupuncture 的是一样的。我 offhand 我是没有它的尺寸在这里，我不记得，其实这么说，这是很普遍的一个acupuncture needle 罢了。重要的是用完就丢，然后它够细。其实很多时候我做完之后，病人都不会流血的，只是用到针就很多人都会怕。
其实还是要跟各位医师讲，不管您是在台湾的医师，或是马来西亚或是新加坡的医师，如果你要学 dry needle 的话，赶快跟我们的陈云之老师学，赶快跟师
他
傅学，对不对？
他
学
简直是
一整
太棒，
套的，对，学一整套的。好，这边还有个问题，就是说，您刚有提到啊，您会请病人做一些 drill exercise，请问你都怎么样教病人做哪些个动作呢？
其实很多时候我们的 muscle 僵硬了之后，很多人都会叫做 isotonic 的 exercise。有时候我叫我病人太复杂，这些人他可能做不好。我基本上会叫病人把嘴巴开大，向前关回来，但是牙齿不咬的、不碰的。这个其实是最主要的，是在那个 lateral pterygoid。lateral pterygoid 是一个比较小的 muscle， 它很容易变成 fatigue。然后我还会叫他做那个 lateral 的 excursion。lateral 的 excursion， 其实有一些文献有告诉我们，可以把它按在这个 temple， 然后往我们的坐正，这个是我们讲的那个 isotonic isometric 的那个它的 action 里头，它基本上是一样的。你其实是要把那个肌肉激活，最重要的就是我们不要咬。所以白天来说，对我来说，很多人治疗的过程里头，忽略了白天病人往往忘了白天花更多时间把肌肉让它紧绷。所以白天如果能够解决它，我想问题应该会解决一大部分。
对，我们中国人常常说，上班的时候要咬紧牙关冲冲冲，可是在这个时候，就是大家有时候工作太认真啦，就会常常记得其实要常常放松自己嘴部的肌肉，要不然一想到咬紧牙根，大家都非常的拼命往前。中国人的特性没办法。
就好
好，
像那个第一个病人的 dialogue 里头，他完全不知道他白天的时候是常常咬牙的，咬得紧牙关那种。
对，好，再来还有一个问题就是说，刚刚有看到您在这个分享的时候，你有做很多的 CT 啊，跟这个 TMJ 的 image，就是那个摄影。那请问我们需要做一些 MRI 这些东西来配合吗？那你为什么
其实
会用 CT 来做呢？
其实很多时候，大部分我的病人都在
医院
我其实也不用说一定要有 CT 在这里头，很多都
，OK，
是 clinic 的 condition，我们就可以处理了。
对
我们可以处理 MRI 是当你觉得它可能有 soft tissue，比如说你真的想要知道那个 disc 是不是跑掉跑去哪里了，你会在 MRI 会看到，而且你会看到 effusion，它的那一个液体堆积在哪里，病人的疼痛不好。有时候我们说，当你要去到那一个阶段的时候，往往病人已经错过了第一次的机会。所以病人在马来西亚来说，我们要叫病人去做 MRI，基本是超级难的一个东西，而且不是一个很普遍的一个治疗的方案。我还没有认真的说病人需要，我的确是有一些人，我治疗了1个月了过后，还是处理不了。有时候我在会想，是不是开始有那个 fibrosis，所以那种 chronic long term 的 chronic 的 inflammation 造成纤维化了，那个是要 MRI 来你才会看得到的。所以我
，OK。
说，我会这样讲，需要的时候就应该要去做，你要知
OK，
道它的 indication。
所以一开始在您的门诊，大部分都还是照一个SAFE 一个 panel 这样子，然后再
开
combine CT 这样就行了。
其实 SAP 的时候，我是在开始怀疑那个他的那个颈椎已
对
经出了问题。大
对
部分的时候，我们的手从他的 history 和徒手去接触肌肉那边，已经可以感觉到肌肉，尤其是我们讲 suboccipital 那个地方 splenic capitis，它的那个后颈的那个肌肉，或者是说我们讲 upper cross syndrome 里头的肌肉，已经知道了。但是我们拍 SAP 的时候呢，其实我是想要去看一看到底问题有多严重。基本上 cervical radiculopathy 那种情况呢，SAP 是没有办法看到的。有时候我们讲，你看到脊椎跑掉了，病人未必会出现麻痹的那个情况。所以我有一个 tip 是这样：如果你是觉得病人是有那个神经的 nerve root 被压到，有一个这样的说法，只要你把手那个这一边的受伤，你把手抬起来，如果他的麻痹会消失，这已经很可能是那个 cervical nerve root 了。有时候我会要先去那个 orthopedic 那边呢，去拍 MRI，尤其是 neck 那边，你是会想看到那个力是不是跑出来压到他的那个 nerve root 了。所以这一个小小的一个动作，有时候病人的手麻痹，尤其是我的第二个 case，他的手麻痹之后，如果你怎样会知道是不是我们讲这个anterior 和 medial scalene muscle 那个空间狭窄了，因为病人头向前倾，它狭窄压到那个神经线和血管，我们讲 subclavian 那个地方，而造成他的手冰凉和麻。或者是说它的源头是在于那个我们的 cervical nerve。其实这个小小的动作，有时候会给我们很大的那个 clue，因为这个拿起来之后，你的 cervical vertebra 那个空间会大了一点。如果它的东西不见掉，这样你就会知道这个很有可能是 cervical nerve 在那个 vertebra 那边，你就会 refer 去给那个 orthopedic surgeon 去做了。当然
太棒了，
physiotherapy
真
是需要。
对，真是一个很好的一个小小的细节。再请教一下，请问您在日常看门诊的时候，你有没有碰到一些做矫正，然后导致会有这个颞颌关节障碍疼痛的呢？
其实蛮多，
也是蛮多的。
蛮多。
那这样您
你要筛选啊。我
是
我其实有一些 case 做到一半，然后嘴巴开不了，
也是做
基
矫正的
本上就是 来的时候就是做了整个嘴巴就是紧绷在那个地方。但是如果是从麻色的 origin， 麻色那边来的话呢，我觉得问题不大。有时候什么都不用做，就是那个热敷冷敷那个东西，病人休息几天，通常你去问他，他都会告诉你，这种小孩子三更半夜都不睡觉，然后 posture 不好，posture 不好，肌肉紧绷，我们只要处理肌肉的问题，处理得好，几天就好了。比较
OK，
难做的是当他 joint 里头出现问题了。
好，所以一样，不管是他今天是什么样状况来的，我们还是要看看他问题是出在哪里嘛。还有您刚刚提到，您会去做一些这个抽血的测试，请问您看这 blood test 最主要是看维他命够不够多吗？维他命 D 还是有没有看是什么东西？您建议我们看的？
其实我是在检查 metabolic disorder， 我检查的是蛮多，我看的东西，比如说，有一些病人他是有贫血的 iron deficiency 的，你可以知道这个地方如果它其实是我觉得并没有一个单独的因素造成的，比如说这个人是贫血的，他的这个 joint 里头，而且他常常睡不好，咬牙。这个地方如果没有得到足够的 oxygenation， 它是很容易发炎的。然后我们去检查 vitamin B complex 的时候，有一个东西叫做 homocysteine， 那个 homocysteine 里头，大致上人家是用来检查 cardiovascular 的那个心血管的。但是如果你懂得 homocysteine 是一个很好的 marker 来检查 B6、B9 和 B3 的话，如果那个 homocysteine 是很高，其实你就知道这个人的维生素 B 群是没有的，或者是他不 absorb 的。所以那个东西很高的话，而且这些维生素在我们的 neurology 来说，它是非常重要，在我们的 neurotransmitter 里头。刚才我所说的 tryptophan 的那个过程要变缓转换成 melatonin， 我们需要这么多 cofactor， 而维生素 D 在这里头的话呢，基本上差不多我每一个检查的都是非常的低。而且维生素 D， 如果我们要讲从营养学来说，它有一个东西是关于我们的 gut， 我们的肠胃，因为肠胃跟 brain 是有连接的，所以这个题我不敢提太多，在这个今天的1个小时里头，因为 nutraceutical 是一个我非常有兴趣的，因为你去归根，你去刨下去的时候，你会发觉到病人身体上其实一大堆的问题。所以如果你说从 metabolic disorder， 你可以看到病人知道了之后，比如说刚才我所说的 acute inflammation， 你要 resolve 它，它其实并不是一个 passive 的，就是说船到桥头，它自然会自己好，其实没有，它主要的是在 omega-3 变化出来的，我们讲的 SBMS。所以如果你的身体是没有那一个东西的，所以我刚才那个 case 3的病人里头，我是有提议他吃 omega-3 的鱼油，他是吃到差不多2个 gram 到3个 gram 一天的。所以 omega-3 里头的主要的功能是让我们可以 resolve information。resolution 其实不是 inhibition， 它并不是，反而药只是阻止那个 immunoresponse， 就像我们开刀之前给病人那些 anti-inflammatory， 你是阻止那个 immune response， 但是我们需要那个 immune response 来，因为它其实是重要嘛 neutrophils 来就是要杀菌之类的，然后到最后他的工作做完了之后，我们需要那个 resolution by way of 那个 SBMS 在这里头。所以我不知道会不会扯得太远了。
不会，不会，不会。真的，我们现在台湾也开始在做一些就是全身性疾患啊，跟牙科共同。其实真的，我觉得我们有的时候啊，现在是越来越需要多方面的去观察我们的病人，他到底处在一个什么样的状况。譬如您提到的这个营养的啦、代谢吸收啦，或者他有其他的一些疾病共同可能会造成他一些身体上的不舒服啦。 那这边再继续延伸刚刚问您的问题呀、因为你刚刚有提到说这个有的矫正病人嘛，他会有 TMD 的问题。那请问，如果是您的病人，虽然你说就是有些小孩子就是半夜不睡觉啊，3、5天之后他就会好了，但如果说这个矫正造成你自己的病人造成了这个颞颌关节障碍的话，你会先暂停他的矫正治疗吗？
其实我讲 mouth occlusion， 在矫正的过程里头，咬合肯定是会不对的。
对，
所以如
对，
果那个病人在这个咬合不对的情况之下，加上其他的那个 factor， 我需要很大力的咬，我变成很紧张，我睡觉睡不好。如果那个 injury 是发生了之后，你希望提供那个空间给他好，我们肯定是需要把那个治疗嘴巴里头暂停。有时候我其实是没有见过，因为我筛选我的病人，那些有 TMD 一来还没做矫正之前，筛选了之后，这些病人有 TMD 的趋向的，我都会很小心。所以我现在在做 braces 的病人，我不会只是单单检查牙科里头的东西，我们牙科太注重形式 mechanical 的东西了。我觉得 TMD 有很多 biology 在里头，就是说
对，
medicine 那一方面，它不是说我们要怎样去做那一个东西，以便可以达到一个效果。我反而会觉得那一个人的心理的状态，他承受的压力，造成他的 muscle overloading， 是一个我们不可以忽略的。
再延伸来问一下，那刚刚提到我们如果说这个病人，你在您的初诊发现这病人已经有一些颈椎的状况了，那这些颈椎状况你判定可能要先请复健科啦，或是骨科啦这一类的医师先看过，那您这样子会同时进行牙科治疗，还是等他复健科或骨科那边看好了一点点稳定了，再请他来做牙科的治疗呢？
马来西亚很少复健科医生会跟我们牙医协同，其实不只是在台湾罢了，我现在也是在找，我有一些好朋友，我也是希望我们能够协同治疗，因为我们跟他讲的时候，颈椎是一个他们也未必懂得玩的东西，他们有很多人都不太愿意去处理颈椎的问题，所以我觉得我自己在颈椎方面的我会很多深入的研究。其实今天我们没有谈到 cervical nerve 的 dermatome， 就比如说那个病人的 motor function 的 sensory function， 其实很简单，你就可以检查到。我从老师 Alex Chen 那边学到一些东西，跟那个卢老师两个人，他把我们打开了那一个界限了之后，你会明白 cervical。如果你拍那个 set 的时候，你已经看到那一个颈椎一大堆的问题了，你的手去触摸它，你检查，你就知道这是一个炸弹，你要很小心处理。所以，如果你有那个知识的话，在病人还没病发之前，你可以一直在控制着教导他做些东西。如果病人是不听的，到最后就好像最后那个名言，老师的名言，治疗都是在人的身上出现的。如果病人不跟随我们的治疗，我只有请他另求
另请
高明。
高明，对对对。
对了，
那请问，刚刚您提到都是说他嘴巴一开始可能是紧咬，或是张不开，或是动作受限。您在门诊上有碰到那种下巴脱臼的，那这样的话你要怎么处理呢？
下巴脱臼我们就把它拖回去罢了啊。但是这个如果当然，好像我所说的，他的那个 eminence condyle fossa 那个我们讲那个 condyle fossa 已经是 flatten 了，有一些人是很久的 DMD， 那个地方either是 development 本来就是不深的，还是很浅的那种情况。这个即使我们在补牙齿、做根管治疗之类的，但很快就脱臼了。其实我心理上已经准备好了，做完了之后就要把它拖回去啊，这是
这样挺
要快
方便的。
点去做啊，这是很方便的。但是你尽
OK，
量都不要做长时间的治疗了。我觉
对，而
得
且它
那个
一旦脱臼了，还
collagen 的
蛮
问题，
容易，对，还蛮容易一直脱臼，一直脱臼的。
因为 collagen 的问题，我们讲 ligament 的 laxity 在这里头哦。我们讲 structural 的 vulnerability collagen 这一种人是一定有问题了的。我看 copper 的时候，我有一些病人我会去验 copper 的那一个我们的 cellular plasmid 蛮贵的，在马来西亚来说。但是你去看 copper deficiency 在这里头的话，你会吓到一跳。有一些病人他很早就白头发，因为我们讲那个 copper dependent 的 enzyme，有一些情况案例会让你提前知道。我只能这样说，脱臼是一个你知道了之后，你就不要做长时间的治疗。
是的，对对对。然后另外啊，刚刚您提到就是您的第一个病人啊，一开始的开场那病人，你在他的咬合板上面有涂上红红的，那是麦克笔涂的，还是什么样子的胶带颜色的呢？
那个应该是 Bosch 那个公司 Bosch 的那个公司，它叫做RD Brax 啊。我是在新加坡购买的那个东西，它其实是我们牙科的材料来的。我有一些病人他完全不相信，即使嘴巴里太多的证据了，他说我没有磨牙，说我就会说我们可以做一个小小的测验罢了。当他看到那个东西的时候，他就哑口无言。因为当他第一天回来的时候，每一天我都叫他拍个照，你就会看到他的 clenching point 和那个 grinding point。你甚至乎 sometimes 你会看到他只是左边罢了，有一些人只是向左磨。所以当你看到的时候，那个就是证据啊。
OK，
当然，如果你说病人愿意给你做那个 Level 2 polysomnography sleep study， 那个更加会看到肌肉的情况，对吗？
嗯，对。哎，再请教一下，这个如果你的这个颞颌关节障碍，它的原因是因为你这康戴尔的这个地方状况来的哦，那这样你还能够做一些肌肉的拉伸吗？会有效吗？
其实你如果说他是在痛的时候，你一定要先解决他的痛的。
对，
所以那个痛，我觉得我们用西药来说是非常有效的，但是它不长久的。如
OK，
果你想看任何的 acute inflammation， 就是 capsulitis、synovitis 那种情况，我觉得我们用西药里头的 anti-inflammatory 它是有效的。但是如果病人就好像最后蔡志猛老师讲的那一个影片，周星驰那个影片，他每一天都在插一刀，你什么药都不
太
会有效。
痛了，没错。所以其
所以
实在他最痛的时候，还是要症状先治疗。但是
对，
我觉得像这一些有颞颌关节障碍，不管是肌肉或是这整个好，现在还不能只有摸 TMD 而已，可能到连头、连后颈、肩颈都有。我觉得其实他是还要配合病人，要有自知之明，他要知道自己怎么样能够放过自己。然后像刚这个您提到的饮食啦，吼，这个营养要备上来。有时候维他命 B 不够，有时候要加一些鱼油，哈，这些东西通通要知道。那也会先让病人清楚，他如果这件事情没有办法自己克制自己的话，相同的状况是不是一定还会再发生呢？以您的状况，
那
它
是肯定。
recurrent 会不会很多？relapse 会不会很多？
如果我觉得他的其他的状况完全没有改善，我们做的东西都是治标不治本。
OK，好，那今天时间也晚了，我们还有一些课，因为一直在问问题，但是问题一直进来。劳医师，你的实在是讲的太棒了，大家有非常多的问题，不过大家不用担心，没关系。我们如果还没有来得及回答的问题呢，我们会请小编帮我们把它截录下来，再送给再请刘医师呢，到时候帮我们
好
线上回答，还有包括您那个。新加坡买的那个红红的，到时候
好，
您再帮大家看看，哎，我们的新加坡朋友啊，马来西亚朋友、台湾的朋友怎么样去买到这些东西？今天晚上
我想
真的很开心。您说。
我想台湾应该会有啊。
没有关系啊，反正我们到时候就整理出来，让广大的安利登的这个牙医师们都可以知道这个好东西。那其实呢，我觉得今天在安利登，我们算是第一场跟 TM Joint 这个地方哦有相关的一个讲题。哎，今天非常非常的热门哎，现场有超多，我们居然有超过400个人，真是太厉害了啦！对，
我太紧张了。
不会不会，真的讲得非常的好，而且呢，真的要提醒大家，我们牙科不是只有那几颗牙齿，不是只有软硬组织，我们其实还有太多太多的东西等着我们去发掘。而且其实，像您也是只有在自己的诊所嘛，对不对？然后在诊所就可以做到这么多的事情，所以各位牙医师朋友们，不是只有在大医院才能够做这些事情。我们即使在小小的诊所，只要您愿意，都可以做得非常的好，都可以为我们的病人提供非常好的服务，而且能够解决病人的疼痛。相信病人这个痛消失了，嘴巴可以动来动去，毫无障碍的时候，一定会用那个星星眼看着刘医师，你实在太神了。那我们下一次也期待刘医师可不可以再给我们这个 Part 2的演讲？今天1个小时实在是不太够，开始大家星星眼放闪。好啦，那谢谢各位医师来到我们今天2025年第一场这个免费的直播，希望你们都能够听得开心。也谢谢我们来自马来西亚的刘医师给我们精彩的分享，谢谢。大家晚安，安利登，祝你新年愉快，拜拜，谢谢，好，拜拜，拜拜，拜拜，大家再见。
Recordings